Welcome to this Peer Voice activity. To access the entire activity, including supporting material, go to www.peervoice.com/kgv. This activity is supported by an educational grant from Regeneron UK Limited. All content was created, reviewed, and approved by the faculty, independently from Regeneron.
Hello, everyone. I'm Dr. Amarnath Chalapalli, consultant clinical oncologist based at the Bristol Cancer Institute in University Hospital Bristol in the UK. Welcome to this activity, which is titled Partnering with Patients in High-Risk CSCC, Redefining the Treatment Paradigm to Optimize Clinical and Patient Outcomes. We know that managing high-risk CSCC is so much more than just achieving clear margins on surgical excision. It's about understanding the profound physical, emotional, and social toll this disease takes on our patients' lives. By combining lived experience with the clinical expertise of our multidisciplinary team, our goal today is to arm you with strategies for integrating therapies and collaborative decision-making so we can deliver care that preserves quality of life for our patients. Joining me in the discussion are Mr. Philip Albury, our patient voice, and Mr. Amer Durrani, consultant plastic surgeon from the Department of Plastic and Reconstructive Surgery from Addenbrooke's Hospital, Cambridge in the UK. In our first presentation, we will explore the true burden of high-risk cutaneous squamous cell carcinoma in patients living with high-risk CSCC. I would start off with giving an overview of the challenges of treating people with high-risk CSCC. In terms of challenges and therefore our opportunities are that we need accurate risk stratification for the disease to avoid a delay in treatment, to also assess the burden of disease both from the disease itself and also from the treatment perspective. Importantly, we need to communicate with the patients what the outcomes from the treatment would be and their anticipated change in morbidity and change in appearance resulting from the surgery. We need to take into account patient factors, as most of the patients are elderly and comorbid, and we need to address logistical challenges in attending the clinic appointments, especially for treatments and multiple visits to the hospitals for radiotherapy, and more recently about integrating systemic therapies into the treatment pathway. I would like to ask Philip to share his experience of being diagnosed with high-risk cutaneous squamous cell carcinoma.
Thank you. My cancer journey started in my early 70s when I attended a dermatology department at the BRI for a medical photography appointment, which revealed this SCC on the left side of the bald back of the scalp and an SCC on the front edge of the bald pack at the back of the scalp. The management plan was biopsy stroke CNC on the urgent pathway. A mid-2024 biopsy confirmed one case treatable with cream and another as squamous cell carcinoma. After advice, I opted for excision, a full thickness skin graft. A full body check also found possible SCC on my leg, and I opted for excision there as well. Surgery took place in 2024. Unfortunately, the posterior scalp issue revealed a high-risk SCC, which was quite close at the deep, which I did not understand, but meant that radiotherapy was recommenced once the wound on the posterior scalp had healed. I agreed to this, obviously, but despite some natural concerns.
Thank you, Mr. Albury. Amer, if I could bring you in, could you describe how to define high-risk CSCC and discuss the potential challenges for surgery in instance of high-risk CSCC?
High-risk and very high-risk cutaneous squamous cell carcinoma are very helpfully been looked at in the BAD 2021 guidelines. And you can see in this slide that they're mainly pathological characteristics that determine risk of recurrence. And those things include the diameter of the primary lesion, the thickness, perineural and lymphovascular invasion, and the anatomical site. This means that the classification and subsequent management of cutaneous squamous cell carcinoma is now far more standardized across the UK, whereas previously management and follow-up geographically might vary quite considerably. So the BAD guidelines have been very helpful in this regard. In terms of surgery itself, this is the primary treatment modality for cutaneous squamous cell carcinoma. And many occur on the head and neck, which presents challenges in regard to achieving margin control. The anatomy means that sometimes reconstruction can be more complex. We see transplant patients who are at higher risk not only of primary cutaneous squamous cell carcinoma, but also risk of recurrence. As surgeons, our goal is to minimize morbidity whilst preserving appearance and function. Around the head and neck, predominantly our concerns are in regard to nerve injury, both sensory, although there's little that can be done to restore sensation, but mainly in terms of movement and function. And it's important to consider the counselling patients and their relatives in regard to how they might appear following surgery, because they will have scars, they may have reconstruction such as a skin graft or a local flap, they may have more complex reconstruction that's required, and there are all the attendant morbidity and risk of things like wound complications, nerve injury, and all of that whilst trying to mitigate against local, regional and distant recurrence.
Thank you. Mr. Albury, your further radiotherapy was recommended. Could you share with us your experience with the radiotherapy treatment?
Yes, I had what I believed my first appointment was in the oncology department in August 2024. That was for the preparation generally, and I had the 4 weeks of radiotherapy beginning in September. From my side, I was able to walk to the centre daily to start with, and about halfway through, I drove halfway, and towards the end, my wife drove me because one of the side effects was tiredness. Apart from the tiredness and localized hair loss, I had, to be honest, no other side effects. I was able to adopt a positive attitude to the treatment because of the friendly and professional way that the hospital staff helped me. They have made me avoid worry or sleepless nights. I was just happy to trust them, and I just did what I was told.
Thank you. Can I just say, looking at the picture, you were asked to lie on your tummy to access the treatment at the back of your head. What was your experience about the mask making and having to lie down every day for the 4 weeks on your tummy?
Well, of course, I didn't have the mask for the first 4 weeks. It was just lying on the tummy. I think it's no more than the fear of the unknown. You get to be concerned about lying there, being absolutely still, and that's always on your mind when you're doing it. But it's not an invasive procedure. It doesn't hurt you in any way, shape, or form. And I just got used to it.
Thank you. Just from a clinical perspective, in terms of challenges with radiotherapy, radiotherapy is generally used as an adjunctive treatment after surgery based on the high-risk features to reduce the risk of recurrence in people who are comorbid, where they're unable to have primary surgery. Then one could consider primary radiotherapy. I think the main issues to contend with from the patient perspective is about the skin reactions, and depending on the anatomy where the radiotherapy is done, associated mucositis or late complications like cosmetic changes also a factor to think about. Coming back to you, Philip, again, during your follow-up, unfortunately, a recurrence was picked up. Could you please share more about that?
During a routine dermatology check, a new lesion on my left eyelid was found, and later my key worker mentioned a possible lymph node. That was the only moment I felt true panic, fearing something serious, as my mother had a similar illness years ago that proved to be fatal. I was referred to the plastic surgery and skin cancer team and came to the terms with the reality that this was now cancer and it was spreading. The surgery went smoothly, and I was very fortunate that I had few side effects. Obviously, there's the question of hair loss, which is one that a lot of people think about. I didn't lose all my hair. It was only in certain areas. I became very tired, but for a long time I was able to walk to and from my appointments, fortunately living quite close to the hospital. And I also, towards the end, found swallowing slightly discomforting, and also I lost my sense of taste, which took some time to get back. But all in all, these were issues that I found very easy to deal with. I think you have to accept that there is a certain amount of problem insofar as people have to accept that they have to give up these weeks of their lives to coming into hospital every day. That in itself is a bit of a it can't be avoided, and obviously the alternative is too bad to contemplate. But it just because the team, and I mean everybody from the Macmillan nurses and the receptionists and everybody else rally round, it just passes. And as I say, I'm very grateful and would encourage anybody in the similar situation to trust the process.
Thank you. I think what this highlights is the need for multidisciplinary management, particularly or multimodal therapy for management of metastatic disease, and the balance between the therapy and the morbidities. We'll pause here for a challenge question. Amer, if I'd like to bring you in again to discuss the makeup and role of an MDT team in supporting patients through their treatment decisions.
So each patient with a diagnosis of cutaneous squamous cell carcinoma is discussed at the skin cancer multidisciplinary meeting. And in attendance at the skin cancer meeting are surgeons, dermatologists, oncologists, pathologists, radiologists, clinical nurse specialists, and other allied healthcare professionals. So there are many different specialists involved, and each case is discussed and a recommendation is made about any further management in the light of the pathology that's presented, and if necessary, any radiology and cross-sectional imaging. There may be local differences in the composition of a multidisciplinary meeting. In some centres, maxillofacial surgeons will be the primary surgeons. In many centres, plastic surgeons in the UK are the primary surgeons. Patients may also be discussed, as in our institution, not only in the skin cancer multidisciplinary meeting, but subsequently if they have more complex, locally advanced disease within the head and neck cancer multidisciplinary meeting. And this allows a more detailed review of imaging and scans to plan subsequent treatment, and in some cases make a decision as to whether a tumour is operable or not if it is locally advanced.
Thank you. Here is another challenge question. Thank you, Mr. Albury, for sharing your perspective, and Mr. Durrani for highlighting the role for surgery and more particularly defining the risk stratification for CSCCs. This was a wonderful discussion. In the next segment, we will shift focus to the clinical perspective, examining recent trial data and the potential integration of systemic therapies in the management of high-risk CSCC. Mr. Durrani, could you walk us through the role for surgery in managing our patients with high-risk CSCC?
The standard management for the majority of our patients is surgery. And the extent of surgery will be dependent on the size of the primary tumour and other characteristics, whether they have evidence of locally advanced disease or even regional nodal disease. The BAD guidelines indicate that the pathological risk of high risk and very high risk cutaneous squamous cell carcinoma. Early referral of these patients via the skin cancer MDT to the head and neck cancer MDT is important, particularly to identify patients who may not be good surgical candidates, who may benefit from other treatment modalities and avoid delay in their treatment, during which time their disease can progress and become inoperable. We need to consider, therefore, when surgery may not be possible subsequently. This may be because anatomically the margins are close and it's not possible to remove any more tissue, such as on the scalp. There may be very extensive perineural spread or what's called stage 4 pathological disease, where there's invasion into muscle, bone or cartilage. This will also be tied up with the pathological features which will be discussed at the multidisciplinary meeting. It can be challenging because if things are not possible to be removed under local anaesthetic, patients may not be fit for general anaesthetic, or the extent of surgery to resect a tumour and reconstruct it. This is particularly important when considering high-risk anatomical locations, and the need for MDT involvement and discussion by all of the people we've outlined previously is critical in terms of providing recommendations to the patients and their families in terms of what the most appropriate management is, but also having lifeboats if surgery is not possible and another treatment modality needs to be employed. It's very important to counsel the patients and their relatives in terms of their expectations, not only about their appearance, but in terms of tumor resection and whether they may require adjuvant treatment afterwards. And all management options and treatment modalities should be discussed within the MDT and then subsequently with patients and their relatives, so that they can come to an informed decision about what they feel is going to be best for them. Dr. Chalapali, in terms of the role of radiotherapy in managing our patients with high-risk cutaneous squamous cell carcinoma, can you outline when you might use radiotherapy and in what circumstances, please?
Thank you. So here I would like to divide the role for radiotherapy in whilst one, addressing the primary tumor, and two, addressing the region if there are any regional lymph node metastases. In terms of after the primary, the indications for further treatment would be mainly positive or closed margins, especially when re-excision is not feasible. If there is extensive perineural invasion, or particularly if there are T4 tumors such as bone or with bone or cartilage invasion. In people where due to their comorbidities, primary surgery is not feasible, then one could potentially consider definitive radiotherapy. I think what is important is to realize the impact or discuss the impact of the patient factors such as the time to recovery from surgery, the logistics of attending for daily radiotherapy treatments, the mobility and physical functioning aspects, and the physiological reserve for the patients. In patients with nodal metastases, if the patients have had more than one lymph node involved with cancer on the postoperative histopathology, particularly if there is extracapsular spread, then one should consider treating the different levels of lymph nodes in the neck or in the armpits or the groin. And that would also mean that it is important, as you highlighted before, that a multidisciplinary team discussion is important in terms of explaining to the patients the treatment paradigm, and also explaining to them that the treatment involves a combination of surgery followed by a postoperative radiotherapy, so that patients are tuned for expecting rather than it coming out as a blue once they finish their surgery.
Dr. Chalapalli, could you highlight the risks of recurrence despite surgery and adjuvant radiotherapy, which illustrate the need for possible adjuvant systemic therapy?
Yeah, thank you. You make an important point. I think generally, despite the standard treatment of surgery followed by adjuvant radiotherapy, the chances of recurrence in high risk or very high risk CSCCs are in the order of 30 to 40%. And therefore, highlighting the need or rationale for considering adjuvant systemic therapy.
Could you talk us through some of the clinical trial data which evidence this, and give more information about the indications for adjuvant chemotherapy?
Sure. I think immunotherapy has established its role, particularly in advanced or metastatic cutaneous squamous cell carcinoma, especially in patients who are not amenable for curative surgery or radiotherapy. I think this is on the back of two studies, one which was looking at cemiplimab in the EMPOWER study, and one which was looking at pembrolizumab in the Keynote 629 studies. Both of them, although done separately in the similar cohort of patients, have established that immunotherapy has got good overall response rates to the order of 40 to 50%, with median duration of response of up to 5 to 6 years. And what the data have highlighted is the safety and tolerability of these agents, with grade 3 to 5 immune-related adverse events being in the order of 10 to 15%. Thus cementing the role of immunotherapy in patients with advanced CSCC. And generally, once there is proven efficacy in the advanced setting, the logical next step is to try and see if we can bring the role of immunotherapy earlier in the patient pathway, and particularly in the context of higher risk of disease recurrence despite surgery and radiotherapy or the combined modality treatment. The role of immunotherapy was tested as a further adjuvant systemic therapy in patients with very high risk disease. In this effect, there were two trials. Again, the Keynote 630, which was looking at the role of adjuvant pembrolizumab for high-risk locally advanced CSCC. This was a phase 3 randomized study comparing pembrolizumab versus a placebo. It was a one-to-one randomization in patients with high-risk locally advanced CSCC after one had surgery with a curative intent, followed by adjuvant radiotherapy. And then patients had pembrolizumab every 6 weekly for up to 9 cycles or up to a year's worth of treatment, and patients were followed up subsequently. What the data has shown that at 24 months of follow-up, the relapse-free survival was 78.3% with pembrolizumab versus 68.6% with the placebo, and they did not have a statistically significant difference in patients with adjuvant immunotherapy. And treatment was well tolerated with and safety was consistent with prior studies, and no treatment-related deaths were identified. However, there was also the CPOST study, which looked at cemiplimab in patients with high-risk disease. Here, what is important to note is that the definition of high-risk disease. They have defined high-risk nodal disease as extracapsular extension with more than one node of more than 20 millimeters in diameter, or if there were more than or equal to 3 nodes, regardless of extracapsular extension. In patients with non-nodal disease, high risk was defined as any of the following: if they had in-transit metastases, if they had radiological or clinical evidence of perineural invasion or of the named nerves, that is perineural spread, if the primary was T4, that is with bone invasion, or if there was local recurrence along with either regional nodes or a high-risk lesion, that is a T3 lesion, which was more than 4 centimeters in diameter, or if there was poorly differentiated histological characteristics in the recurrent lesion. The design was similar to the keynote study. However, the important point was that patients have had to complete post-operative radiotherapy, and they were randomized within 2 to 10 weeks of completing the radiotherapy. They were randomized 1:1 to cemiplimab or placebo, and cemiplimab was given for a year with the primary endpoint of disease-free survival. And this is the highlight or the main takeaway is that the cemiplimab has shown significant improvement in disease-free survival with a hazard ratio of 0.32. And in terms of safety, the patients have tolerated it well, and the testament is the very low rates of adverse events leading to discontinuation, which is less than 10% in these patients. And the common side effect was diarrhea, fatigue, and pruritus, which was similar to what was seen in the EMPOWER studies.
From my perspective as a surgeon, if patients can don't have comorbidity and they're eligible for surgery followed by radiotherapy, I think that the likelihood is they would be eligible subject to the MDT discussion for adjuvant treatment. But fortunately, the number of patients that we see with this extent of disease is relatively small. How often do you encounter patients who fulfill the criteria in your practice?
Yeah, you're right. I think the couple of points there. One is important about the shared decision making in the MDT, but actually, luckily, we do most of our patients do present early, and we don't need the whole gamut of adjuvant treatments. But nevertheless, there are always instances where we would see patients with higher risk disease where one would be eligible for adjuvant systemic therapies.
How do we consider and mitigate the balance of benefit versus side effect and risk from immunotherapy for these very high risk patients, Dr. Chalapali?
You already alluded to it. I think it is important that we look at address the patient's comorbidities and the rate of recovery from their surgery and adjuvant radiotherapy side effects. And once the patient is fit enough, then certainly I would be looking at discussing the role for adjuvant systemic therapy, particularly if they fulfill the high risk criteria. And as I showed in the trial data, in terms of safety and tolerability, the adjuvant treatment was well tolerated with low rates of grade 3 or worse side effects. Therefore, in patients who are fitter and able to tolerate the treatment, certainly we should be discussing with them. Here is a challenge question.
So we've agreed that multidisciplinary collaboration, whether it's via the skin MDT, the head and neck MDT, or both, is critical to support patients through the treatment process. What do you think best practice looks like for an MDT managing cutaneous squamous cell carcinoma, which is high risk or very high risk?
I think one of the important tenets for our management of these patients is the MDT discussion and shared decision making. I think it is important to recognize that from their imaging characteristics or their previous high-risk disease characteristics, we could potentially highlight people who are more likely to require adjuvant treatment after surgery. And it is at that point, right at the beginning, to explain to the patients that they are likely to require further therapies after surgery in view of their high-risk disease, so that they're mentally prepared to go through the whole thing. And we address the whole treatment, such as surgery, followed by adjuvant radiotherapy, followed by adjuvant systemic therapy, as the whole package, so that patients are more amenable and more receptive to be able to expect that there is more treatment to come if they have high-risk disease.
From my perspective, the individuals, the healthcare professionals who are the glue that hold the service together are the clinical nurse specialists, the immunotherapy nurses, the Macmillan nurses, both within the hospital and within the community, and the specialist skin cancer nurses. And they are involved from the start of the process as they attend the multidisciplinary meetings. And then they link with each other and between the oncologists and the surgeons to ensure that the patient and their relatives' journey are as smooth as possible.
Yeah, yes, I couldn't agree more. And I think they form a very crucial linchpin between the referral pathway and keeping the patient's pathway on the straight and narrow. Here is another challenge question. Thank you all. This has been a really rich discussion. Hearing the clinical and patient perspectives together is exactly what we need when managing complex disease like high-risk CSCC. And I think this discussion has been incredibly valuable, and I hope you find this valuable too.
This has been an activity published by Peer Voice.